So good morning, everybody. At the outset, I'd like to thank Dr. Gaurav for making me a part of his course. And I'd like to congratulate the entire local organizing committee for wonderful arrangements at this beautiful venue in Coimbatore. Yes. So I'll be speaking about the Phaco emulsification in Intumescent and the Morgagnian cataracts. So we all know that Intumescent cataracts, they always pose a great problem to any cataract surgeon because there is an increased intracapsular pressure in the capsular bag. So this is one stage capsular access if you want to do in this Intumescent cataract. So at some point you lose it and you have Argentinian flag sign like this. So these are very old videos, 12 or 14 years old videos. So there is another way of debulking the capsular bag. You just give a nick in the anterior capsule and start debulking with the cannula. So sometimes if you are lucky, you may succeed in debulking the capsular bag without extending the capsular axis, and you can convert this capsular axis. But the problem here is that when you are trying to debulk through these irregular margins, these margins may give way from any side, as you can see. So the technique which I presented in ESCRS 2010 Paris, what I call is a sequential two-stage capsular axis works best in my hands at least. So I always give analogy of the Intumescent cataract to this dome. As you can see, if you want to walk on this dome, the central area of the dome is the safest one. If you want to walk on the mid-peripheral area, there are high chances that you'll slip down. So the same principle applies here. You can see the spokes of the liquefied cortical matter, which is increasing the intracapsular pressure. So I go ahead and give a small nick in the anterior capsule and use a microcapsular axis forceps to make a very small opening in the center. And you can use a high molecular weight OVD if you have with you. Otherwise, you can also do with the simple HPMC in cases like this. So once you have this small opening in the center, this is very robust opening. It doesn't give way. So now you go ahead with the 27 gauge cannula, and you can see the whole cortical matter is coming in this cannula. Go from the side port, debulk, and as I'm aspirating, you can see the whole capsular bag is debulking, and the pressure in the capsular bag comes down. So go from the main port, from side port, from second side port, and debulk the capsular bag like this. And after this, I use a micro scissors here, give a tangential cut. And now, because there is no increased intracapsular pressure, you can make a capsular axis of adequate size of 5 or 5.5 millimeter in the one go. So now I'm completing the capsular axis. So you should have these microcapsular axis forceps and these micro scissors, which comes very handy in situations like this. Most of the cataracts, these Intumescent cataracts, they are very brittle, so there is nothing great in chopping them. But still you need to be careful as there is no cortical support there behind the nucleus. As you can see, I given the first chop and there is no cortical cushion which is there, so you need to be careful that you don't have any surge so that your posterior capsule doesn't come in the phaco tip. So step by step you chop them and eat them like a piece of cakes. Always slow down on your parameters when you come to the last piece. This is the Morgagnian cataract. The problem in Morgagnian cataract is different. There is no raised intracapsular pressure as such because as soon as you give the nick, the whole cortical matter comes out. But the problem lies with the loose zonules and the fibrotic anterior capsule which is there. As you can see, when I'm making the capsular axis, this capsular bag is moving along with this. So you need to support with the other instrument if you want. And because of these fibrotic plaques which are there in these kind of cataracts, sometimes the capsular axis size may be smaller. So you again need to enlarge the axis before you start your phaco emulsification. Now the whole nucleus here is very small and it's very mobile, so it's difficult to get a good grip on the nucleus. As you can see, it's rotating freely in the capsular bag. Now the trick here is to go with the bevel down and get a good purchase of the nucleus, and once you have that, pull it towards you and get the chopper from the equator. There's a classic horizontal chop as we know, and divide the nucleus in smaller pieces, and again, there is no cortical cushion here, so you need to be careful that you don't have surge in your system, which may compromise the posterior capsule. This is another case, the Morgagnian cataract, the whole, you can see there is only nucleus, there is no cortical matter here. So I go ahead, stain this capsule and make the capsulorhexis. And as I'm making the capsulorhexis, as you can see, I'm using the support of the nucleus. I'm moving the nucleus to get first the support, then secondly to get a good visibility of the stain and take capsule. So I keep on moving this nucleus and complete the capsulorhexis of adequate size here. And once you have the capsulorhexis, again go ahead, bury the phaco tip and chop it into smaller pieces using the horizontal chopping technique, and the whole nucleus is out, and here goes the capsular, the IOL in the capsular bag, and with this completes the case. So I think in Intumescent cataracts and Morgagnian cataract, it's nowadays with the decent machines which we have and the techniques which we use, it's very easy to get away with these kind of cataracts. Thank you very much.